Welcome. My name is Krista.Beckwith, and I am a maternal health specialist in the Maternal Wellness Program at CDPHE. My work focuses on maternal health with a specific focus on perinatal mood disorders and maternal morbidity and mortality. Within perinatal mood disorders, the state prioritizes addressing pregnancy-related depression. I act as the lead for the state's pregnancy-related depression efforts, along with Mandy Bukolski, maternal wellness and early childhood supervisor. So a brief overview of what this presentation will cover. We will go through how CDPHE came to focus on this topic. We'll do an overview of our work to date on pregnancy-related depression. We'll review what to expect as an advisory committee member, and then we'll go over where you can find additional information. So first, let's go over where in CDPHE the pregnancy-related depression efforts are housed and how the work is funded. The Maternal Wellness Program oversees the state's pregnancy-related depression efforts. This program is housed within the Children, Youth, and Families branch within the Prevention Services Division of CDPHE. The Maternal Wellness Program also oversees the state's Maternal Mortality Review Committee and associated maternal mortality work, and additionally conducts ancillary projects in preconception health and other areas. The Maternal Wellness Program Supervisor, Mandy Bukolski, is also the supervisor of the state's early childhood systems work. This was a strategic setup to ensure work being done in the early childhood realm is connected to maternal health. The Maternal Wellness Program is funded by Title V Maternal and Child Health funding. These are federal dollars commonly referred to as the MSPH block grant dollars because MSPH funds are provided to each state based on a formula. CDPHE, as the state health department, is responsible for implementing the state-level work under the MSPH block grant, and they are also responsible for passing funds through to every local health department in the state. Each local health department receives funding that is also based on a formula. Every 5 years, the MSPH block grant requires Colorado to complete an extensive community needs assessment. Through our initial MSPH needs assessment, completed in 2010, pregnancy-related depression was identified as a priority area that is currently lacking in resources. As a result, the state developed logic models and multi-year action plans to begin addressing the topic. These action plans speak to both state and local efforts and act as a roadmap for work to ensure everyone is seeking to address the same goals and achieve the same outcomes. Pregnancy-related depression, or PRD, was one of 9 priorities identified as a result of the needs assessment. Other priorities are looking at things such as teen motor vehicle accidents, youth sexual health, and medical home. The Maternal Wellness Program is responsible for implementing the state action plan. Local health departments could choose any of the 9 priorities that they wanted to implement. If they chose PRD, they would be responsible for implementing the local action plan. These action plans focus on systems-level work to improve population-level health. This means that neither the state nor local health departments will fund direct services to address PRD. Instead, the work should be focused on improving the systems of care pregnant and postpartum women operate in. Each year, the state reviews the action plans to identify modifications that may be needed to the objectives or activities to ensure that they reflect what is currently happening around the state. CDPHE invested a lot of time and effort into developing the pregnancy-related depression state and local plans and followed the Bronson model of evidence-based public health. Currently, we are on step number 6 and are implementing our action plans. At the end of this presentation, I will provide you with information on where you can find the action plans for review. The state and local efforts to address PRD are measured by one of Colorado's data points on the Pregnancy Risk Assessment Monitoring System, commonly called PRAMS, a comprehensive questionnaire that is filled out by new moms in Colorado, usually between the 2nd and 4th month postpartum. The data point is the percentage of mothers who report a healthcare provider talked to them about what to do if they felt depressed during pregnancy or after delivery. The goal is to increase this percentage from 75% to 80% in 2016. While the current percentage of 75% looks to be fairly high, this can be misleading. Nearly one in every 9 Colorado women who gave birth from 2009 to 2011 experienced signs and symptoms of depression. This is roughly 7,500 women each year, and experts in the field suspect that this is underreported. National statistics often vary from 15 to 20% of moms developing depression. This makes depression the most common complication of pregnancy. So if we relook at this data point, it currently is saying that 1 in every 4 women are not being told what to do if they experience the most common complication of pregnancy. In Colorado, we define pregnancy-related depression as depression that occurs during pregnancy or up to 1 year after giving birth, including after a pregnancy loss. This topic is also commonly called maternal depression, perinatal depression, postpartum depression, as well as many other types of names. We intentionally chose pregnancy-related depression because we wanted common language that was easily relatable amongst many populations. And additionally, we wanted to ensure that we included both pregnancy and postpartum, as well as those who may not carry the pregnancy in the first place, including partners, grandparents, etc. Additionally, we seek to be inclusive of adoptive parents who may also experience depressive symptoms. Since identifying pregnancy-related depression as a priority, the state has accomplished a lot of work. The maternal wellness staff spent most of the first year assessing local and national efforts. Staff spoke with numerous other states to identify lessons learned and challenges and successes experienced. The program also completed an extensive statewide survey with over 600 responses to understand where local communities were having success and where we could best provide support. Staff then recognized the need to develop supplemental guidance for those caring for pregnant and postpartum women. In 2013, the state contracted with Health Teamworks to bring together diverse stakeholders from across the state to develop this guidance, formally entitled the Pregnancy-Related Depressive Symptoms Guidance. This guidance, along with the supplemental tools, have received both local and national recognition. Staff also recognized the need to provide professional development opportunities to increase both awareness of and knowledge on pregnancy-related depression and perinatal mood disorders at large. In late 2013, the state partnered with the University of Colorado College of Nursing, the Colorado chapter of the American College of Nurse Midwives, and the Association of Women's Health, Obstetric, and Neonatal Nurses to host a summit on perinatal mood disorders. The summit was positively received, and the state is looking at opportunities to provide additional professional development in the future. Thus far in 2014, maternal wellness staff have been focused on implementing the Health Teamworks guidance and enhancing its partnerships with stakeholders. Additionally, Colorado has been funded by the Association of Maternal and Child Health Programs to further develop its maternal mortality work. This includes testing out a data system for the CDC and implementing data-to-action activities. Staff are committed to ensuring that the data-to-action activities align with the other MCH efforts already being implemented. As most of you can attest to, work on pregnancy-related depression is ongoing, and Colorado still has a ways to go. CDPHE recognizes the ongoing efforts that are needed to improve policies and systems, and have recognized that the most common barrier to improving these policy and systems and processes is not knowing what to do once the screening is done. Until we can equip providers and programs and communities to feel empowered in answering this question, our work cannot fully move forward. Additionally, we must identify and address the need of public awareness on this issue. The state has intentionally delayed addressing this need because staff recognize that we must first ensure the systems are equipped to address the issue prior to bringing more awareness to it. And this is where you come in as a member of the Pregnancy-Related Depression State Advisory Committee. In 2014, the Advisory Committee will be tasked with the following 2 items. Number 1, focusing on resources for pregnancy-related depression. What is needed in Colorado, and how can public awareness about resources be improved? Additionally, what should public health's role be in the development and distribution of resources? Number 2, public awareness and education on pregnancy-related depression. What does this look like in Colorado, and who should be the target audience? As a reminder, these questions were posed as part of your original application. Throughout the year, the Advisory Committee will be engaged to identify and assess issues related to these 2 areas, be asked to define and redefine how the state should move forward with work in these areas, and finally, provide recommendations to CDPHE on how that should be implemented in 2015. So what to expect as a member? So in 2014, the Pregnancy-Related Depression State Advisory Committee will operate in a 2-tiered system to increase participation among interested stakeholders. Tier 1 members will be actively meeting in person, and Tier 2 members will be engaged exclusively via email. Tier 2 members will be invited to meet in person at the September meeting. However, in-person attendance is not required to remain a Tier 2 member. In-person meetings will be 2 hours in length and will rotate around the Denver metro area so that we can all share in the travel. These 2 hours will predominantly be focused on obtaining information and input from you as the advisory committee. So, rather than reporting out on state progress on work during meetings, all advisory committee members will receive a brief state update prior to each meeting. This update will highlight upcoming activities, successes to date, challenges, as well as information on how our work is going thus far. We will provide time at each meeting for you to ask questions about the state update. Additionally, prior to each meeting, you will be prompted by email to provide any updates you may want to share with the group. We will have a very clear deadline on when to provide me with these updates. Please provide them to me in a ready-to-distribute cut and paste format. We will then compile these updates and share them with all advisory committee members via email. You are also encouraged to bring flyers or hard copies of announcements, resources, reports, things that you've done to the meeting. Providing communication in this manner will ensure all members of the advisory committee receive the same level of information, including those who are being engaged exclusively via email. And I recognize that this might be a different sort of setup for an advisory committee than what you've been used to in the past, and we ask that you work with us in trying out this new format, and we will adjust and make changes throughout the year as needed. So what should I expect in March? So prior to the first meeting, you will receive the first state quarterly update, agenda, prompts for feedback and the due date, that will be for Tier 2 members only, and requests for program announcements. For those on Tier 2, you may receive your email with prompts for feedback after the first in-person meeting. However, you will receive the state update and requests for program announcements prior to the first meeting. So where can I regularly access information? So you can access information in a couple of ways. All agendas, state updates, announcements, and prompts for input for those on Tier 2 will be emailed to you as attachments. The Pregnancy-Related Depression State Advisory Committee also uses a set of Google Doc folders. Within this set of folders, you will find the state and local action plans, agendas, updates, minutes from prior meetings, and other relevant documents. You do not have to have a Gmail account or even be logged into a Gmail account to access these folders. I recommend that you save this link within your browser, and it will be included on the emails that come from me. The Maternal Wellness Program also has a set of web pages on the Colorado.gov website. On these pages, you will be able to find recent reports, trainings, activities, and other resources. Again, I recommend that you save this as a website within your browser because neither one of these links is necessarily considered user-friendly in terms of format. And so as a reminder for those of you in Tier 1, we will be meeting in person on Wednesday, March 19th from 1:30 to 3:30 at Kaiser Permanente in Aurora. And please feel free to contact me prior to March should you have any questions, and I look forward to engaging with you all throughout the year. Thanks.